our pharmacy drug list. And so they have to demonstrate how those get filled, or if there's a request that comes in, they can walk us through the system to show, what's the life of a prescription. So, so that's readiness. I really don't have anything else yet. We're going to be doing a bigger kind of in-depth presentation in May on this, where we'll have a lot more information. But is there any questions I can answer right now? Yes, sir.
Thank you.
Yeah.
You mean at the May Choice Board meeting, you're going to do a more in-depth
Yeah.
presentation?
Yep.
Okay. Thank you. So I have three questions or areas. First of all, as you may be aware, we had quite a bit of discussion during the legislative session about whether there would be a residency requirement for individuals performing services under an MLTSS contract. So we have been assured that there will be no residency requirement, even though there have been conflicting messages around that. So can you state definitively for everyone here and everyone listening that no person employed by a AAA or a case management company or any other entity will have a requirement that they reside in Indiana?
There is no requirement that says that they have to live in Indiana to be able to do service or care coordination with the MCEs. We did put that in the contract. We put it under the service coordinator job requirements and clarified it basically, so that we could be compliant with the request of the legislature. And so though actually it's done, and the contracts have been entered into the system, and they're actually out with the MCEs. We're waiting for signatures at this point.
Well, that will be a big relief. So thank you. And that segues nicely into my second question, which was is about contracts. So you say the contracts are ready to go with the MCEs, right? So what is the timeline for the MCE contracts to be executed? And then behind that, what will the timeline be for the subcontractor contracts to be executed, namely with the AAAs and the case management companies?
So I can answer the MCE contract. The subcontracting with the CCHI entity is still in process. I believe that they're getting closer, and I'm kind of looking this way to see.
CCHI being the care hub?
Yep, that's the care hub. They're getting closer together. I know Cora and Kim and Dan met last night to help facilitate some more information between the MCEs and the AAAs. So it's definitely going forward. The MCE contracts should be back. We asked them to have them back and signed by the end of next week. So we should have them back by the end of next week. And then we will have another update. We can provide another update on the CCHI and MCE. I can send something, or we can have something sent to the what this gives you more definitive information on that CCHI and MCE relationship.
You mean well prior to the May meeting?
No, yeah, I mean like after this.
Yeah.
I can go, yeah.
I mean, is it fair to say that FSSA's expectation is that those contracts with the subcontractors will be made available and negotiated and ultimately executed timely? We're not going to get to July 15th and have the contracts presented to the care hub for retroactive implementation to July 1, and it's a take it or leave it with no discussion or negotiation.
So I would say that the actual contract, and I know Tarek's on here, he might be able to answer some of this too, but I know that the contract language itself is in a good place. It's, I believe, rates that they're talking through right now. So again, I can email, I've not been part of those discussions. I would rather send you the information straight from Cora's mouth so that I'm giving you the right information on where they're at and where we expect them to be in the next upcoming weeks. We're going to have to be done with a contract very soon, because we got to get them trained and the MCEs trained on working together.
I might be able to shed just a
Sure.
little bit more light on that. So we don't have like a specific deadline that we're shooting for, but we are actively working on helping everybody kind of work together to resolve those and get to a good spot from a negotiation standpoint, provide whatever guidance is appropriate from the state. So the intent is definitely to get that in a good place very, very soon here. We definitely don't want this to be a post go live discussion.
Right,
We're really
right.
trying to help everybody get it wrapped up
Okay.
as soon as possible, because I know everybody on both sides are anxious to get it done and get this formalized and figured out.
Okay. But you'll keep us informed
Right.
as a choice board, and you can send out information through Ms. Hardy. Where'd she go?
Yes.
She's somewhere.
Yeah.
She disappeared.
Yes, I
You
can.
are doing an outstanding job of anticipating my next question because you mentioned reimbursement. And that's my third area
Okay.
of questioning is just where are we with the reimbursement? And I think we got a little piece of
Yep.
that just now. But again, I know a lot of folks are very concerned about timelines because, like back home, my own AAA is looking at budgeting and staffing and
Right.
all the other things. And obviously, they can't have staffing in place for July 1 go live if they don't know how much they're going to be reimbursed until June 27th. So I'm
Right.
hoping that a lot of this can be resolved, within the next month or so that they have a couple months of time to ramp up and deal with whatever they need to deal with at home.
I was always told that hope is not the strategy, but I hope as well that we have this wrapped up by the end of, it doesn't go out past April because we really need to start planning on what that training looks like for go live for both of the entities that are coming together.
Okay. And I know there continues to be some confusion, at least concern over what the reimbursement is going to look like because we've changed terminology a few times along the way. We went from talking about case management to talking about care coordination to now talking about service coordination. And I think, whatever we call it, I'll use the word hope again, which I agree is not a strategy, but I think many of us hope that the reimbursement, will reflect the work that the AAAs have done in the past, regardless of whether it was called something else, and continue to allow them to support their workforce, whatever the function is called on paper. It's going to be a lot of the same people doing a lot of
Right.
same or
Same
similar
thing.
things, even if we change the name of it. And we need to make sure that the AAAs are in a strong position, especially recognizing the workforce situation today, that they're competing not only with all of the other employers with whom they've competed in the past, but now we're hearing some stories about poaching, and I think that's an issue that FSSA may have to address down the road if you're not already addressing it, because I don't think it's okay, for poaching to go on where a AAA is being put at a disadvantage, as a subcontractor with their employee going to work for an MCE.
It is on our radar, the poaching, and we've brought it up in our previous month, which was February, plan president touch points with them. I don't want to say it was a formal discussion, but it
Yeah.
was very informal that, we want to make sure that they're not poaching AAA current staff. Current staff that apply, there's not much they can do about that, but they can't actively recruit.
Right. Right. Well, I'm glad it's on your radar. I appreciate that. I know a lot of others do as well. And I think it's something to continue to monitor closely, recognizing that we want everyone to be successful here. We want the MCEs to be successful. We want the AAAs, the case management companies, other providers to be successful. And ultimately, we want Hoosiers and the state of Indiana to be successful, right?
That's our goal.
Yeah.
100%.
So thank you all three for your presentation and answers.
No problem. Thank you.
Kim's gonna. Can you hit the next slide? Kind of reiterating that we have started to see some of those pain points that we're hearing, and we're in anticipation of that, really been pushed for trying to fill those gaps in both the education and outreach training. And so I know we just put some examples of what we're doing for the member outreach, but we're doing a lot of training and outreach, both to the members as well as to providers, to the AAAs, to like any of the stakeholder groups that are actively engaging in the to make the success of Pathways go live. So here we are just demonstrating some of the outreach that we have done. We have gone through and done presentations to members in the northern part of the state this past week. This current week, we are doing central Indiana and have been doing direct to provider or direct to member engagements. And then next week, we'll be doing the southern part of the state. We have a full schedule, and this is just a sample of some of them where we're offering those kind of town hall meetings where members can come and engage with our team to be updated and educated on the enrollment process. In addition to this, we also are doing more operational trainings with other providers. We've already done a contracting training. We're going to be doing claims training this next month in April. We're doing service plan training as well as authorization training. And we're doing that not only to the direct providers, whether it's the IHCA members or HCBS members, but also to the AAAs so that we're all on the same place. And the nice thing that we've had is we're having unified presentations with all three MCEs. So instead of having it fragmented system, we're making sure the MCEs processes are flowing identically to make it as smooth as possible so that this transition is successful. So, sure.
Thank you. I see Yellowwood Terrace in Clarksville, if I'm seeing it correctly. Is that March 28 from 3 to 4 p.m.?
I agree that I think this is the latest updated.
Yeah. Have you been sending these out to the local media in each area?
We have Advancing States that has been promoting it, and we've been promoting it through the AAAs as well. I'm not sure what the media outreach was for
Don't
that.
know if we've done local media outreach. I know we've reached out to various stakeholders, but that may be an area that we have not.
Yeah,
Do
I can loop back around and ask.
Yeah. Do you have something that I could send to the newspaper in Clark and
Yeah.
Floyd counties to
Sure.
get a
We have
blurb in here in the next
flyers.
few days?
Do you have copies of those? If not,
I
I'll.
do.
Okay, yeah.
Can you just shoot that over to my personal address and I'll get it over to the News and Tribune to make sure folks are aware of it? Because that's a week from today. So if you can get it to me today or tomorrow, I will get it right over to them. And
No,
then
we
that-
greatly appreciate it. The more turnout, the better. We
Yeah.
feel we feel like
Absolutely.
it's easier for us to be able to communicate face to face if at all. Several of them can't come face to face, so we do have some virtual
I see 2 of
webinars that
those.
we're
Yeah.
doing that first week of April to help to cover those people who can't come in person.
I think that's great. Thank you.
Well, thank you very much.
Are there any other questions for Kim or Holly?
Yes, this is Representative Jackson. I'm looking here and I don't see where we have any upcoming meetings for Northwest Indiana. I'm up here in Lake County.
I
Yeah.
apologize. We only put the upcoming. We did the Northern Indiana route last week. And
Okay,
so there was a whole series that we'd already gone through the Northwest and the northern part of the state. So
okay,
we can get you the list of what was presented and what locations that were there, but anybody who was not able to attend those, we're hoping that will go virtual at this point.
okay. All right, thank you.
Any other questions? All right, thank you, ladies. Okay, next, Carissa, would you present the choice dashboard?
Hello. Is it picking me up on the microphone? Okay. So hello, my name is Carissa Atherton. I am the Associate Health Data Analyst for the Division of Aging. And I've been working in collaboration with some other Division of Aging folks, as well as some fabulous eImagine team members to put together a Tableau dashboard. It is currently still in draft or beta form, but I wanted to sort of share the progress that we're making to get feedback before the initial rollout. So next slide, please. So first, just regular things like team introduction. I'll do a little bit of a recap. I presented at the last meeting, but I wanted to present some of it again for folks who weren't here, or just sort of a refresher, and then go into some of the updates that have happened since the last meeting, as well as go into some next steps for the dashboard. And then I'll have a slide at the end with my contact information for any feedback and final questions. So first up, just the team members. The team members here, we have myself as well as Aaron Wright and Andrew Bean on the Division of Aging side, and then a wonderful crew of eImagine folks. We've added some new people since last time, Ashia and Courtney. So yeah. Next slide, please. All right, so the purpose of the dashboard is really to provide an in-depth look at the choice data that we already have collected and stored, just to make it more accessible to the Division of Aging staff. The data will be updated as often as possible without compromising on the data quality, as opposed to what we have now with like annual reports or just snapshots from like one-time requests. This way we can monitor changes over time in the choice data. Another perk is that the dashboard can be easily added to, modified, and tailored to specific topics or use cases. And these changes and updates will be ongoing based on user feedback. And then finally, the dashboard will allow some quick and easy access and dissemination of up-to-date and verified choice figures. So this is the sort of main page. I apologize, it's a little bit small, but it focuses on participant demographics. You can view the percentage of total choice participants by many different demographic factors, which are listed on the sides of the map in the middle. These include race, ethnicity, gender, marital status, poverty level, living arrangement, veteran status, and even duals category. All of the graphics on the page can be used as filters just by clicking on them. You can even select multiple filters to make it more specific. For example, you could look at divorced participants above the poverty level who live with family, just as an example. Next slide, please. So in addition to the main demographics page, we also have some other pages. The main one right now is the duals and choice page, which centers choice participants who are dually eligible for Medicare and Medicaid, or duals. They can be categorized based on Medicare savings program and Medicaid coverage level, as shown by the acronyms on the side. Right now, this graph is tracking participant enrollment over time from January 2022 to the present day. This can also be filtered based on those participant demographics for more specific information. So now I want to go into some of the updates. We updated the main map. So now that the darker green represents the proportion of choice participants compared to the total population within each AAA. So as you saw in like the previous map, area 8, because it has the largest population, is pretty much always going to be the darkest green, or the highest percentage of choice participants. But now it is within each AAA, or on the right we have within each county, which will allow us to better compare across AAAs rather than just out of the whole state like before. So we can see now that like area 12 has the highest proportion of choice participants compared to all participants within a AAA, if that makes sense. The same goes for the county level. And when the map is filtered using demographic filters, it will show the proportion of choice participants in that demographic. So we can see if one AAA or county has a disproportionate amount of choice participants with a certain demographic, such as like living alone, things along those lines.
Question.
Yes.
Thank you. What time period does that reflect? Is that an annual snapshot, or is that a rolling illustration?
Yeah, so this is actually all current active participants as of right now. That's the great thing about this dashboard is it can be used to look historically for some things as well as what is active right now today.
Is there going to be a way to view this historically, these maps?
We could certainly set that up. That's actually really great feedback.
Just something to think about,
Yeah.
because I think the snapshot in time is just that. It's a snapshot in
Mhm.
time. And so I think it will be good to be able to look at current usage of the program and historical usage, maybe over a previous year period or a previous 12 months rolling average or something like that.
Yeah, absolutely. That is certainly something I believe we could accomplish.
Okay, thank you.
Any other questions before we move on? Okay, so this is another new addition that we have, services and spending. It looks at choice plan services as well as service quantity and costs over time, starting in January 2022 to the present day. You can view all these services together, but there's kind of a lot of them. So you can also select on the side which services specifically you would like to look at and compare a handful or just look at one over time. And then finally, we added some new content to the dashboard for both use as filters and individual graphics. First, as shown on the left, I apologize, this is really small, but this is total diagnoses within the population. So the diagnoses are broken into ICD-10 code groupings with breakouts for diagnoses with a high prevalence or things that we might have a special focus on, such as hypertension, arthritis, and um, so on. The graphic can also be filtered by whether the diagnosis is primary, secondary, or tertiary. It can also be used as a filter. So we could look at that first demographics page of the choice participants, but only include those with dementia, for example. Another addition is the activities of daily living count. It is currently primarily being used as a filter for other graphics, but we have the graphic on the right added to the main demographic page. And then finally, we added just some data for other relevant programs such as Medicare, Medicaid, Title III, SSBG, and the waivers, primarily for comparison purposes. It's used in our map that shows the proportion of choice members for the total population served in the AAAs, as well as some comparison for the non-waiver service quantity and costs.
Question?
Yes.
So it is very hard to see. Will a user be able to filter ADLs by primary, secondary, or tertiary diagnoses?
Yes, you could absolutely do
Okay.
that.
And then will you be able to tell, like for each primary diagnosis, what the most common secondary diagnosis is?
We don't have that functionality built in now, but I believe it would be absolutely possible. And that's a really great suggestion.
I think it might be informative
Mhm.
I'm just thinking particularly primary and secondary, maybe tertiary,
Mhm.
but to know, if the primary diagnosis is dementia, then underneath that, what are the most common secondary diagnoses?
Yeah, absolutely. I think that would be great for looking at like comorbidities in the population. And
Yes.
such. So I really
Mhm.
appreciate that. That's
Thank
really
you.
valuable feedback. Any other questions before I move on? All right. So just some next steps. We're currently working with some subject matter experts on our data team on a social determinants of health page for the dashboard. The goal is to highlight some of the choice data that can inform decisions about non-medical influences affecting the population, like nutrition, behavioral health, and then knowledge and access to services are the main areas that we're looking at. But after we finish assembling, quality checking, and testing the dashboard, the next step is to release the dashboard internally to Division of Aging staff before the next choice board meeting. We are also planning a public facing version of the dashboard for the future, but that will take a little bit longer to complete.
With the social determinants of health, is there anything there that specifically would address socialization or contact with other people, or kind of addressing that loneliness issue? Or are there any questions or data that could be reflective of that?
Yeah, so we can certainly look into it. It's difficult to know, like we're
Right,
pulling primarily from our like case management system.
right.
So if it's not tracked in there, we're looking at some alternative data sources at the moment, like the NCIAD, for example, is a big one. So we can certainly look into that. I think that would be a great area to address for the dashboard.
I think your point in the past has been as well, like for Meals on Wheels or hand delivered meals, that that there's one contact that,
Mhm.
that we may want to be able to quantify.
Yeah, absolutely.
Are there any other questions?
What's the timeline?
Yeah.
What's the timeline for the publishing the dashboard internally?
Yeah, so we hope to have the initial rollout by May 6th. But of course, this will be an ongoing on developing dashboard over time. So we can always add stuff to it
Sure.
after it's published.
But if it's May 6th, then it would be in time for us to
Mhm.
take up at our May
Do it at the next meeting.
choice board meeting.
Mhm.
Yeah, absolutely.
Yeah.
I hope to have a demonstration available next
Yeah.
time.
Oh, wonderful.
Yeah.
Yeah, I mean, it'd just be interesting to keep the discussion going. It doesn't have to be pretty.
Yeah,
If
absolutely.
it's not totally ready for prime time, I'm fine with that.
Okay.
I think it's exciting. So
Yeah.
thank you for your work on it. Great presentation.
Thank you. I'm glad. And the last slide of the PowerPoint has my contact information on it. So if there's anything else you think of, other feedback you might have, feel free to contact me and let me know. But I appreciate all the feedback so far.
Thank you, Carissa. All right, Leslie. Welcome back.
Thank you. I'll cover a couple of different updates today. I want to give a quick update on the choice budget for this fiscal year. I'll cover some Medicaid forecast strategies updates, and then just some other general Division of Aging updates. So first, just a quick update on where we are with the choice budget for this fiscal year. We do track throughout the year to try and hopefully make sure that we're spending as much of the choice appropriation as possible to provide services for folks. We always try to look at that mid-year to see if we can amend the AAA contracts and reallocate if necessary in order to maximize the amount of spend for the choice budget to reach as many folks as possible. So we did take a look mid-year like we always do. It was looking like we were going to revert back around $3 million. So we did reach out to the AAA network and did get some agreement among the AAAs to reallocate some of that funding to some other AAAs that were projected to spend their full amount before the end of the fiscal year. So we are in the process of amending those contracts. In order to reallocate the funds, we have to amend several AAA contracts, which does take some time. So we are working on that. But the AAAs have been notified if they are receiving more allocation, or if their contracts are getting amended to pull back funding as they've agreed to, so they can start planning for that spending to hopefully make sure that we revert back as little as possible, which is always the goal. So our hope is that we'll continue to shrink that number down.
So just for my simple mind, basically you're just readjusting. Is that correct? So some have an abundance, some have already depleted, and so we're readjusting that within the system of the different AAAs.
Correct. So
Okay.
we, at the beginning of every year, we have the 15 contracts with all the AAAs. We have a funding formula, so it gets allocated out, but it's always a little bit of a guessing game on who's going to spend what and how much. And so again, we're trying to make sure as much gets spent as possible, but because there are 15 that you spread it through, it does take a little bit of puzzling to kind of get all that together and maximize
Mhm.
the spend as much as we can. But the AAAs have been really helpful as a network and kind of flagging for us and helping us predict, whether they're going to hit target on spending or not.
Okay.
Okay. I will shift into some of the Medicaid forecast update. So I know you all heard a bit in January, and if you are on our listservs or spending any time on our website, you would have seen lots of information flowing out over the last couple of months. So I just wanted to highlight a couple of things. One, I knew there were a couple of questions that came up. It may have been with the Commission on Aging, but just in the interest of sharing information across both, I'm just going to address a couple questions that had been flagged in January. One was regarding that 2% Medicaid rate index pause. There had been a question on, how much specifically were we estimating would be a cost savings with pausing that rate indexing. So for that particular piece, we're estimating approximately $27 million in state appropriation savings for the current biennium across all the impacted provider types. So that would be the HCBS, home health, ABA, NEMT, and dental.
Savings based on what? I'm sorry.
So when we did the HCBS rate increases last year, we had also built in a 2% rate increase per year until we did the next rate review. One of our strategies in response to the forecast variance was pausing that 2% rate index. And so there had been a question of how much are we projected to save by pausing that. So that was that 27 million.
Right. So the savings to the state, though, comes at a loss to the providers. So I think, going back to what I was asking about earlier regarding workforce, we have to be very mindful of the workforce situation. And, I have heard from a lot of providers who, were pretty excited about the 2% indexing and are now pretty disappointed that that's not going to be there. And it's not a question that you can ask, but I think the question, we all need to be prepared to answer is, it's being presented as a pause, quote unquote pause. Is it really going to be a pause? Does that mean that when we hit play again, to extend the metaphor, that 2% will come back along with the next 2%, or is the pause really 2% that will never be put in the base? Does that make sense?
It does. And I think that's an open question, right? I
Right.
mean, I think that it just depends on where a lot of this ends up. And, we'll have a budget year next year too. And so I think there's still lots of discussions to come, but your point's well made, right?
Yeah.
I mean, we know it's hard. It was something we were really happy to have gotten in place too for that predictability factor as well. And so it's,
Yeah. Well, again, I know you can't answer the question, but I wanted to raise the issue because, as I said, I think, we all need to be prepared to address it at some point, because providers, understandably, want to know, is it really a pause or is it just going away?
So another question that had been asked was clarity on the number of legally responsible individuals impacted by some of the changes with shifting legally responsible individual care from attendant care to structured family care. I don't have a number on that yet. We have over the last 2 months been collecting a lot of data with that. So last month we did a provider survey data where we asked all attendant care providers that we asked all attendant care providers to submit a survey response letting us know, do you have any legally responsible individuals providing care under you as a provider agency? And if so, send us a list of all of them. And if you do not, send us something confirming that you do not. So that was our first step. We are now working with care managers as well to do a survey with them to say, if you are providing care management for a family where there's a legally responsible individual providing care, we would like you to have a discussion with that family and collect some information and submit that to us. And so we know the care managers have been working hard over the last few weeks to collect that information and get that to us as well. And then one additional thing we've built in to continue to try and collect information on this and get clarity is building in on the claim form for some of these different provider types, an area where they need to submit information if a legally responsible individual is the caregiver for the service claim that they're submitting for reimbursement. So we should have a lot more information, a lot more concrete information on that number here in the coming weeks. We've got some information rolling in. It's just not that final number yet, but we're getting to that and getting a lot more visibility, which will help us, one, with predictability in all of this, but two, also know what families we need to work with for this transition period.
When is that survey due?
So the initial round was due last week. We know some care managers were having trouble making connection with families. So we're trying to work with them to kind of shore up those remaining surveys that are out there.
Okay.
On the transition for attendant care to structured family care for legally responsible individuals, we are working with providers in order to help them make the transition to structured family care if attendant care providers want to provide structured family care with this transition as well. So we did create an expedited provider certification process for attendant care providers that want to become structured family care providers. That does not waive any of the requirements to be a structured family care provider, but it does essentially bump them to the top of our queue so that we can work through that certification process as quickly as possible. So we did open that up very recently. We already have 100 attendant care providers who have gone through that certification to become a structured family care provider. And we've got another more than 200 in the queue waiting to get through that process too. So we continue to work with providers, trying to build up that provider network and support that transition as
What
well.
was the first number?
Around 100.
100
100
Mhm.
already,
complete and 200 waiting.
right? And that's, yeah, that's statewide, but that is folks who've already been, these are LRIs already certified for the structured family caregiving.
So it's attendant care providers, right? So it's the provider agency that's acting as the attendant
Oh, I
care
see.
provider agency. And so
Oh,
they
you're
can-
talking about agencies,
Correct.
not the term provider.
It's
is
a little,
often-
yeah, it's a little
Yeah, because we
confusing
talk about
yeah,
provider
yep.
agencies and then we talk about who's actually providing the care. So, so you're talking about what we'll call provider agencies, not caregivers.
Correct. Yes. Yep.
That's a lot of agencies.
It is. Yep.
It's a lot of agencies to get transitioned between now and July.
It is. So they are, we have that amount certified. We've got that pipeline built in to get them through the certification process. We've also, through the waiver transition, there will be that additional oversight happening both with the Medicaid team, with BEADS for those on health and wellness waiver, and then with the MCEs for those that'll be on pathways. So recognizing it is more providers in a new space too, we're trying to work in what we can as well to make sure there's appropriate oversight and support for those providers too, as they're kind of learning the lay of the land on this new service as well.
Will you be able to give us a report at some point about geographic dispersion?
We should be able to, yeah.
So, I mean, because one of the discussions that we kept having around this issue during the legislative session was, the adequacy of provider agencies in, throughout the state. That I think there is a recognition that there simply aren't providers in some communities, especially rural communities. And it would be, I think it's an opportunity as you are taking inventory of everybody to, maybe a spreadsheet or a spreadsheet and a map, a county map, showing us what the coverage is.
Mhm. Yeah, I think that's something we'll be looking at
Mhm.
anyways, but we should be able to put that together. I don't know if it would exactly be a heat map, but we can at least get, the number per county, maybe number of members per county as well, and kind of project that together. So.
Yeah, I mean, I'd like the basic data to start. We don't necessarily need a fancy heat map. Folks who are interested in the data can easily divide by population and, get a rough idea of what the um, provider capacity is based on population for a given county, for example, if you have the data by county.
Yeah. So another update I wanted to provide is on service plan review. So one of the strategies we identified was making sure we were reviewing service plans in a detailed way to ensure alignment with the service definitions within the waiver. We had some auto approval functions set up in the past that we are turning off to make sure that we're really taking a close look at those service plans, make sure the needs of the individual are reflected in the service plans, make sure, again, that we're in alignment with the service definitions in the waiver themselves. It also helps us understand if there are areas where we need to push out additional training or education for care managers or for providers. And along with that, we have started bi-weekly care manager webinars to provide that additional training and guidance, and also give them an opportunity to ask us questions so we can continue to really try and provide more detailed feedback to them, and provide assistance and support as we're working through the service planning and working through those processes. So that sort of deeper dive service planning approach kicked off this week and will continue as we kind of move forward into the waiver transition into pathways as well. But will help us, like I said, just make sure we've got a good eye on what we're seeing from a service plan perspective and provide that additional education and training as well. And we have brought alongside additional team members and vendor support to help with that. Because we in the DA are a small but mighty team. So we wanted to make sure we had enough folks brought alongside to make sure that we were still moving through that process quickly and that folks weren't waiting longer than necessary for services. The last piece for the forecast strategies that I'll update on is retroactive eligibility for the waiver. So we did identify back in January, one item that was both a compliance and a cost savings approach is turning off retroactive eligibility for the waiver. So we're finalizing some FAQs that will be going out here fairly imminently, just clarifying when we say retroactive eligibility, this is what we mean, this is not what we mean, to make sure we're providing as much information as possible for providers, but also for consumers and care managers. So that will be coming out here soon, will be sent out via our listserv, and will be on that Medicaid Strategies webpage that we've been maintaining. Yes, sir.
Why do we want to eliminate retroactive eligibility?
So there were a couple issues with that. One, it's a compliance issue. We actually don't have authority under the waiver to retroactively apply waiver eligibility. The second piece of that is it's very challenging from a predictability standpoint on the number of individuals having a spot on the waiver, the spend under the waiver to have this retroactive process as well. So there were a couple of different factors that played into making that change, the compliance being the biggest one, but also one of those items we identified as part of our forecast strategies.
Yeah, but we could apply for a waiver amendment, right?
So
To be
we don't
compliant.
believe that it's actually permissible under waiver authority. None of our other waivers allow for this retroactive eligibility, and I'm not aware of any other states that do it this way. Our expedited waiver eligibility was really the path that we've identified long-term to address kind of that speedy access to waiver services.
And which waiver are we talking about here?
The
Which-
Asian disabled waiver.
Right. Which is going away.
It will become two different waivers.
Right,
So it'll be the pathways and the health and wellness waiver.
Right, but I mean, we won't refer to it any longer as the A&D waiver. It'll be
Correct.
two other waivers.
Mhm.
But I mean, doesn't, and maybe this is a discussion that we can put a pin in and revisit at the next meeting, but doesn't this go to the heart of, um, HCBS versus institutional care that,
Fast access to services.
yeah, in order to have a level playing field,
Right.
we need folks to have access to home and community-based services the same way that they have access to institutional services.
It does. And so I will say we are not the only state that grapples with the challenges of getting speedy HCBS access, right?
Right.
And so knowing that retroactive eligibility is not authorized under the waiver, the other options we have explored are things like expedited waiver eligibility. We've also started a waiver eligibility process work group with the Division of Aging and some of the AAAs to explore how can we get through the assessment process a little faster and ensure good quality with that as well. So we are working on lots of different paths to try and still ensure speedy access to HCBS. But we have to do it in compliance with the waiver at the end of the day. And so that's the path we're trying to work towards.
Yeah, I mean, I would be interested to learn what is permissible,
Yep.
you know, what CMS will allow, and how other states have addressed it. So maybe you could consider that for at least a brief presentation at a future meeting, because you get my point. I mean, this again goes to the level playing field that I think most of us want to create between um, you know, facility-based care versus home and community-based care. So I don't want to sidetrack on it, and I appreciate your answers, and I'd like to learn more about it.
Yeah.
Thank you.
So the last thing on that piece I'll reinforce is really just, we do have a Medicaid Strategies webpage that is the source of truth for all the things that I'm talking about here. So all the updates I've given, there is information on the webpage about each of these pieces. I highly recommend monitoring that webpage, signing up for our listservs if you're not on them, so that you're getting this information that we're sharing out. I'm always happy to provide updates, but that is kind of that source of truth that we're using. Yes.
Source of truth.
Source of truth, yeah.
That's a big phrase.
Yeah.
Will you ask Ms. Hardy to send out the link to the
Yes.
source of truth? And I think I'm on the listservs already, but just make sure that we have all those listed, so that anybody who is on the choice board or members of the public who may be watching or interested can sign up for all that.
Absolutely.
Thank you.
So I will move on quickly because I know we still have, I want to make sure Kristen has plenty of time for her update. So just wanted to give a couple other additional Division of Aging updates outside of Medicaid waiver stuff. So I did want to highlight a new app called Caregiver Way that is for supporting family caregivers. It was developed by Joy's House, and Division of Aging was happy to provide some support for that development through some of the additional COVID funding that we received. It's has really, really great content. It launched last week to support family caregivers, everything from practical advice and videos on how you can support your family member through different activities of daily living, to a journal page, access to community forums, access to content for things like life after caregiving, which we aren't talking about a whole lot, but is really, really important. So just wanted to highlight that that was out there. They will be presenting on that app in the Commission on Aging meeting in May. We talked about that earlier today. So happy to, if the chair decides would be a good idea, have her present for the May meeting for the Choice Board as well, time permitting. But I just wanted to highlight that that was something really exciting that that has launched recently to support family caregivers. Couple other quick updates. The Dementia Care Specialist Program that was part of House Enrolled Act 1422 last year is we're finalizing those contracts and getting those ready for signature. We did share with the AAA network what the budget is per service area for that program. So a lot of them have started hiring. I've started to see job descriptions and job postings out there on LinkedIn and different places for the AAAs. So they're getting geared up, and we're really, really excited for that to get kicked off here really soon. We in the Division of Aging have hired a legal assistance developer. So this is something required under the Older Americans Act, and it's been a very long time since we've had a dedicated role for that in the Division of Aging. And so Bill Lutz started with our team this week as our legal assistance developer. The purpose of that role is to coordinate legal support services available for older adults around the state. So not to necessarily create a state-driven program itself, but to kind of coordinate all those different programs around the state, understand what community resources are there, identify gaps that might be there, and help facilitate kind of addressing some of those gaps. So we are very, very excited for Bill to be on board and starting that important work.
I'm very excited to hear that, because my home community is Valparaiso, and we had a lot of assistance from when we had the law school, and then that was closed by the university. So we've had a really big void in our area. So that's wonderful that we'll have a resource.
One last item, the multi-sector plan on aging. So you've heard us talk about that periodically over the last year or so. We are working to finalize and get scheduled our kickoff meeting later this spring for that multi-sector plan to get folks together to start putting together work groups to build out and draft that multi-sector plan for Indiana. And so that's intended to be a 10-year plan to drive policy on how we should approach supporting aging Hoosiers, especially as that aging population continues to grow in Indiana. So more to come here in the coming weeks and before the May meeting on that.
When is the May meeting?
The our meeting or the multi-sector kickoff.
The multi-sector kickoff.
It is
meeting.
not on the calendar yet.
Okay.
We're aiming for mid-May. So as soon as we do have that on the calendar, we'll have some invites going out for folks.
And by our meeting, you mean our next choice board meeting?
Correct.
Okay, yeah, that's in May.
It is, yes.
Yeah.
Yeah.
So what's the timeline from that multi-sector meeting?
So we'll have the kickoff, and at that kickoff, we'll be talking about the different work groups that will be supporting the different goals identified for the plan. And then over the next several months, those work groups will work together to develop recommendations on what should be in the plan itself. And then we will be drafting the plan. And we are, our initial timeline, we're trying to be fairly ambitious, and we'd like to get it drafted before the end of the calendar year. Part of that, we'll see kind of how things go as we get those work groups together. We want to make sure we do it well, not just quickly. So, but we also want to, keep momentum going with it. So that's the goal.
So as some folks may have heard, this is a gubernatorial election year. So the new governor, whoever that is, will inherit this plan.
Yes, I think they will. So this was identified as one of Governor Holcomb's agenda items, was supporting our development
Right.
of the MPA. So our hope is that it will be something that anybody can support, because it's an important initiative and really, I think, an important way to plan for the future for Indiana, and really, not just prepare for that increase in the aging population and that change, but also embrace it in a lot of ways too. Because there could be some good opportunities there. So that's the goal.
Yeah, I mean, obviously, it will be important for the next governor to embrace the plan if it's going to be successful. So has that been discussed?
So that is our hope, is that it will be embraced by whoever the next governor is. So we don't know who that is yet, but I do know, there'll be lots of opportunities for engagement at lots of different levels in the coming months.
But this is a 10-year plan.
It is.
And what plan does this replace?
It does not replace anything. We do not have anything like it in Indiana currently.
I mean, we've had strategic planning before on issues around this, but it's not, I mean, I know there's not a corollary plan that it's replacing, but do we have any other multi-year plans that are coming to an end or that are still in effect that will overlap this?
We have the state plan on aging that we submit to ACL every 3 years. So we'll come alongside that. That is something we develop on a rolling basis, and we'll continue to have, obviously, because it's part of our Older Americans Act work and different initiatives there. But otherwise, I'm not aware of any multi-year big strategic effort like this. I know other states are in different stages of development of similar things too, but.
Right.
Yeah.
But the 3-year plan is required by
Correct.
the feds.
Yep.
So I assume the goal will be to have the 3-year plan or the 3-year plans, I should say, because there'll be there'll be 3 or 4 of them during the 10-year plan, right? To have them sync up
Yes.
with the 10-year plan.
Correct.
But that will inevitably involve the next administration as well.
Correct.
Okay. Just trying to understand all the timelines and all the plans for plans. Thank you.
That was the last of my updates. Does anybody have any additional questions or anything I didn't cover?
Are there any additional questions? All right, Leslie, thank you and welcome back again. We're glad to have you with us, and we did thank Andrew for his time. Kristen, are you ready to present? We should have I think we need source of truth bracelets. Like
It's a good idea. Source of truth. Right?
let's the source of truth.
Like one of those.
We could snap ourselves with it
I don't know about the snap.
if it's good or bad.
Good afternoon, everybody. I'm Kristen Law East with the Area Agencies on Aging. And before we get into the meat of kind of the presentation and packet today. I wanted to tag on to Representative Clear's recognition of Senator Breaux. Your packet does include the article announcing her passing as well as her farewell statement. And she was such a champion, as Representative Clear said, for the choice board and for the work that we did. She worked so hard to understand the complexities of long-term care and the interplay among all the different funding sources, which most people don't even realize happens. And, you know, many times, you know, we'd have discussions about a bill and have to talk about how choice worked with Medicaid and where did older Americans come in. And she just worked really hard at that. She's carried legislation in the past for us. Back in 2012, 2014, we did honor her with a Legislative Champion Award. So she's somebody who's been very important to the AAA network over the years, and appreciate the recognition the Choice Board gave her this afternoon. So at the federal level, important things are happening for the Older Americans Act. And, you know, it's kind of the basis of the AAA network and the basis of the Division of Aging. And it is being reauthorized for the first time in 5 years. And while the services, as long as there continue to be federal appropriations, will continue, the act is really, when it gets reauthorized, it's what gives us the opportunity to modernize it on an ongoing basis. There were recently final regulations published that implement the act. They hadn't been updated in 30 some years. And as hard as the new regs tried to modernize implementation of the act, it still ran into barriers because of the act itself. And so we're taking this as an opportunity to kind of push those regs and all the flexibilities across the finish line in this reauthorization. We are fortunate in that Senator Braun is the ranking member of the Senate Committee on Aging, and he sits on the Senate subcommittee that reauthorizes the Older Americans Act, and he has taken a very strong interest in ensuring this act does well, not only by all AAAs, but in particular Indiana AAAs. We've been working with his staff in communicating our priorities for reauthorization. The first item in your packet after the articles about Representative Breaux are an RFI that members of a Senate cohort have been circulating, including Senator Braun. There are 6 to 8 senators that are working in a bipartisan manner to write this legislation from the Senate perspective, and he's on that group. And so you'll see that RFI there. You can see the kinds of questions they're asking. The RFI is due tomorrow, so unless you have a wild hair tonight, you might not be able to submit something by the deadline. But the good thing is that we're having ongoing conversations with his staff member, Eric Rasmussen, in Senator Braun's office. Has set up a series of discussions with us. And if there are things that you are concerned about or have an interest in, please feel free to forward those to me, and we'll think about how we throw that into the mix of the conversation, even outside the RFI. In terms of the priorities for the AAA network, I've excerpted kind of a one-pager in that summarizes the goals, as well as the entire statement or article on the Older Americans Act from US Aging. Regarding those priorities, there are 4 that really impact our AAA network that I wanted to draw to your attention. The first is that one of the things that the Older Americans Act and the update in the regulations have caused confusion about is State Union on Aging oversight of outside contracting by AAAs that do not involve Older Americans Act funding. And we've been in a good situation in our state, and that our Division of Aging has taken a very light hand in just ensuring compliance related to Older Americans Act, but there are other states that have interpreted that a lot more stringently. you know, in a worst case scenario, the Division of Aging would be looking at every single contract that Real Services, who is a CAP agency, not just a AAA, you know, lets, or for our AAAs that are housing developers, or our AAAs that are transportation providers. We do a lot of stuff outside of Older Americans Act services. So I feel confident in saying the Division of Aging does not want that role. And we're going to try to make sure they don't have it. So that's one of the things we're trying to fix in the act itself, is to clearly identify what the state's responsibility is and isn't related to that outside contracting. Number 2 is creating additional flexibility in the nutrition titles. Currently, there are 2 titles for nutrition: home delivered meals and congregate meals delivery or provision. There is some transfer flexibility among those 2 titles, but we feel that the fact that there are 2 separate titles is a barrier to innovation and local flexibility. And this became apparent during the pandemic, when we had to figure out, how do we do grab and go meals? How do we figure out restaurant vouchers? How do we, you know, do all kinds of stuff that don't fit neatly into those categories? And so we're just saying, just make it one big title. And it's the AAA's responsibility to respond to local needs. And there will still certainly be home delivered meals, and there will still certainly be congregate meal programs. But let's let there be maximum flexibility, both from the state perspective and the AAA perspective. The third area, again, comes out of pandemic. And the current act requires that any healthy aging prevention programs be what's called evidence-based, which is kind of a highest level designation for these programs. However, when everybody had to transition to virtual, many programs across the country had to discontinue their healthy aging evidence-based programs because the evidence base did not support virtual delivery. And so what we're suggesting is that we ratchet back that language slightly to evidence informed, so that local AAAs have the flexibility to respond to emergencies and other kinds of local conditions that make it difficult to deliver a program that is evidence-based with complete fidelity. So we're not saying evidence is bad. We want evidence informed, but this creates more flexibility. Finally, the current administrative percentage in the Older Americans Act is limited to 10%. In kind of nonprofit land, generally, the more standard, you know, you see standards of 18 to 20% is considered efficient and, I'm losing words, efficient and, you know what I mean? It's okay. I'll come up with that word in a minute. But so what and in Indiana, if you think about the kinds of things we do in care management, we're collecting clinical information about consumers, we're collecting diagnosis information, we're collecting protected, personally identifiable information. And as a result, our state requires all of our AAAs to be HIPAA compliant. And the cost to maintain that HIPAA compliance, particularly with all the technology considerations, continues to skyrocket, both in terms of hardware and software and personnel related to that technology. It has to do with insurance, cyber insurance we all have to have, and those costs keep ratcheting up. And just the labor cost inflation related to qualified staff to oversee and properly administer these funds. You know, your accountants, your CPA, your executive director, these are costs that have also inflated radically. And so we're saying, you know, it's really time to allow that administrative allowance to flex. And so we're asking for an increase in that cap.
To what percent?
Our national says 12.
Okay.
I'm talking with Senator Braun to at least 15. But we'll see what comes out. There's a lot of other people that have a lot of opinions about that.
Okay. Thank you.
Okay, so that's kind of everything on the Older Americans Act. Does anybody have any questions about that? So further back in your packet, we have also included not only U.S. Aging's complete statement on the Older Americans Act, but also their entire set of federal public policy priorities. From our state's perspective and our AAA network, we're focused on the Older Americans Act because of our ability to influence through Senator Braun, as opposed to the broader set of initiatives. The last federal thing is that there's a notice of proposed rulemaking out on accessibility of medical diagnostic equipment. So if you think about having to go to the doctor and climbing up on an exam table, a lot of people can't physically do that. And so that's an example of something that would have to change with this update to rulemaking on accessibility of medical diagnostic equipment. So so if you have an interest in that, that is available for you to take a look. And that's kind of the last of the federal stuff. And well, in the last few minutes, I did want to talk about the outcomes of the legislative session. The first thing I want to do is really can't give Representative Claire enough recognition for the yeoman's work he did on behalf of our network during the legislative session in ensuring a couple things. One, that the legislation and the language we wanted to move, providing to improve and enhance the membership of the Choice Board and the Commission on Aging actually got in a bill and passed. And so that was thanks to Representative Clear's work that happened. And as you heard during part of the presentation, he was also trying to help us with the residency issue, which, because we weren't getting anywhere, we started to have to make it a legislative issue. And with his advocacy, was able to get that to a better place. So would you like to say anything? You pulled the mic over like, like you were getting ready.
Thank you. It's a great network. You know, I'm a fan. And so are a lot of other people. And it was definitely a team effort in addition to you and your lobbying firm at the State House.
RJL.
You know, yeah, we had a lot of other parties who were interested in not only that language, but other parts of the bill, which in addition to addressing some important issues around aging, or maybe setting the stage to address some important issues around aging with respect to the Commission on Aging membership and the Choice Board membership, and adding housing to the discussion and so on and so forth. The bill also contains important language related to disability and mental health. We got some mental health language in at the very end, and it turned out to be a great bill. But I wanted to thank you as well and acknowledge all the folks who helped get it across the finish line, because as you know, it was one of the it was a little nerve-wracking. It was one of the last 5 bills that passed, at least in the House. I didn't look at the Senate's final calendar, but I believe it was on the Senate's final calendar as well. But it was a team effort, and once more to acknowledge Senator Breaux. I pointed out to one of the news outlets yesterday that it turned out that House Enrolled Act 1067 was the last bill to pass with her name on it.
Oh, that's gonna make me cry. I've been getting a little kind of emotional just thinking about
It made me a little
all her work,
emotional
and that
thinking
really
about
just
it.
that really put me over the edge.
But I just thought, you know, what an amazing legacy, and to have the last bill with her name on it, impacting people with disabilities, seniors, and mental health, really says a lot.
What a legacy. Thank you.
Amazing
Thank you
legacy.
for sharing that.
Yes, thank you so much, Representative Claire. I have been pretty quiet today, trying to hold back from saying too much. I spent Friday with Senator Breaux at the facility there. She was, I just have to share it with you all for a moment. So forgive me if I'm just a little emotional, but she was very upbeat that day. She was just so eternally thankful for her 18 years of service and for the people that she has touched and those lives she has helped to change. And even up to the last minute, she was asking her mom, former Senator Billy Broke, to check her emails and check this and read them to her. And I mean, she was still trying to work from her from the facility, and it's as if she knew that she was not, well, she knew that her time was limited, but it was as if she was trying to do everything she could possibly do as long as she was in her right frame of mind. And I will never forget that. And I just really, really, really appreciate all that she's done, not only on this board, but for the entire time that she's represented those individuals who are in need of help, not only the AAAs, not only on the choice board, but those as well as the maternal mortality. So I'm going to stop talking now. Thank you.
Thanks for sharing that.
You're welcome.
So the last two I'll point out two additional bills that passed: Senate Bill 109, which we advocated on very strongly, which gives FSSA flexibility to kind of implement APS however they choose. And even before the bills were dropped into committees, we were meeting with Senator Crater and asking what kind of advocacy he wanted, and making sure that got across the finish line without controversy. So we've talked before about why it's important that FSSA can do that. The last bill is House Enrolled Act 1385. And this was has language that really AARP championed quite a bit. We wanted to put our support behind it as well because it forwards the mobile integrated health movement in Indiana. Because we're kind of out of time, I won't go into the details of it, but it's in your packet. And hopefully we'll have more to talk about in mobile integrated health and synergy with the AAA network over the next year. Moving forward, Representative Clear is working with us to get a couple study committee topics going, one on the use of Medicaid in housing. So there's an article in there about the state of Nevada that just got approved to do that. There's also another article related to social isolation, loneliness, and elder maltreatment. Social isolation is another topic of study that we're asking to be looked at over the summer. Lots of implications for health, for abuse prevention, that kind of thing. Finally, the last thing I'll mention is that you may have seen in the national news, in the Washington Post and New York Times, articles about this massive urinary catheter scandal happening in Medicare. And it kind of makes it sound like that this national association discovered it and alerted Medicare, and it just happened in January. And our good old Senior Medicare Patrol Network in Indiana and across the country was actually talking about this last August. And we were seeing these kinds of complaints come in from consumers that were just identifying these charges on their Medicare summary notices and calling Medicare and calling their S&P to say, I think there's fraud going on. And so in your packet is promo material for a television news story that's airing tonight on WRTV that features this, including our program director, Nancy Stone, as well as examples of some of the Facebook messaging we've been sharing starting last August and September about it. So if you get constituents, you can direct them to our SMP, and we'll help people understand how to report it. And we also train people on how to protect themselves from Medicare fraud and medical identity theft, how to identify it, how to report it, detect it, and report it. So I'll stop there.
Okay. Are there any questions for Kristen? Are there any comments to come before the choice board? Hearing none, I will state that the meeting is adjourned at this point. Thank you all for your attendance and thank you for your presentations.
Thank you.